the medical team of USV. And a very warm welcome to all the speakers and our expert panelist for CME India today, brought to you by Dr. N.K. Singh, no other than Dr. N.K. Singh, sir, in collaboration with USV. And today's topic of discussion will be insulin resistance, from molecular mechanisms to clinical management. And without a further ado, let me have the privilege to introduce us, the driving force behind the CME India, no other than Dr. N.K. Singh, sir. Can I please have the slides? Next slide, please. Sir is the Director of Diabetes and Heart Research Center, Dhanbad, Chairman RSSDI, Executive Member of National RSSDI, ex-governing body member, and an admin and founder of CME WhatsApp India Group. It's great to have you here with us today. Once again, sir, I welcome you on behalf of Team USV. And over to you for the further proceedings.
Yeah, good evening to you all, audience and our respected faculties, and our today's very eminent speaker, Dr. J.B. Sattur, sir. So I have great pleasure in welcoming you all. Can we get the next PPT of Dr. Sambhu Samajdar? That J.B. Sattur will be introduced by our panelist. So you will go to the next. Please go to the next. Yeah. So I have great pleasure today that we have got a very eminent panelist, Dr. Sambhu, is consulting physician, diabetes and allergy, asthma therapeutic specialty clinic, Kolkata. His faculty at so many hospitals, fellowship in respiratory and critical care, diploma allergy, asthma immunology, published. You see more than 104 articles in indexed medical journals. Rather, I'm surprised that every day he is publishing at least one article. So that is a great, and more than 50 book chapters, fellow of Diabetes India, so many organizations. So he is a great person. Welcome you all. Next panelist, can you go for the next? Yeah, so again, a great pleasure to welcome Dr. M. Balasubramaniam. He is the PhD, FMS, and so many degrees you can see here. He is the ICMR emeritus scientist, professor, and advisor from this Madras Diabetes Research Foundation, Chennai. Postdoctoral scientist at the New Jersey Medical School, New Jersey, USA, and faculty at the Center for Biotechnology, Anna University, Chennai, Dean of Research and Senior Scientist of the MDRF, Chennai. And he has got more than 150 papers on this subject. You can see here the diabetes biology and molecular medicine, biomarkers, diabetes and metabolic disorders. Fellow of National Academy of Medical Sciences, India, fellow of Tamil Nadu Academy of Sciences, Chennai, and is a, I think, great scientist today we have got. Welcome you, sir. And our next panelist is Dr. Amitav Vishwas. He is MD, FICP, FIA, CM, and FIMS from the Yama Care Unit Center for Diabetes, Obesity, and Metabolism, Durgapur, West Bengal, and chairman of the Bengal Diabetes Foundation. And he has been the organizing secretary of the HappyCon 204 Haryana State Annual API Conference, past president of API Gurgaon chapter, and past president of Diabetic Forum Gurgaon, and past chairman Indian Medical Association. And also I welcome Dr. Akash Singh. Can we have the CV PPT of Dr. Akash? Yeah, so Dr. Akash will be today give a concluding remarks with his current designations are the senior consultant of medicine, diabetology, non-international cardiology at Baroda, Gujarat. He is the invited faculty and speaker of so many state and national conferences, several publications in international Indian journals, reviewer of many journals, and also a book author of the Management of Diabetes, Complete Practical Guide. So welcome Dr. Akash Singh also. So now I request Dr. Sambhu Samajdar to formally introduce our today's speaker, Dr. J.B. Sattur, sir. So Dr. Sambhu.
Thank you, sir. Can you have
display the CV PPT of Dr. J.B. Sattur?
Yeah. Can you just initial slide?
So thank you, sir. First of all, I must say, as you were telling about daily publication, the most important thing is the team members. And just like insulin resistance, it has multi-dimensional, and we will try to learn from Dr. Sattur, sir. Also, this publication depends on the team you have. And I am also really fortunate to have a great team members. Also you, Professor N.K. Singh, sir. I'm really privileged to have you on board and for guiding me in different projects. So it is a really pleasure for us to learn about insulin resistance from molecular aspect to clinical aspect from Dr. G.B. Sattur, sir, who is a renowned clinician, researcher in this field. Sir had done his MD, MRCP from UK and FICC. He is senior physician and diabetologist, chairman at Association of Physicians of India of Karnataka State Chapter during 2018 to 2019. He is also the governing council member of KIMS Hubli. He got Best Speaker Award in International Cardiovascular Conference in 2019 at Nepal. Also, he got Dr. V.C. Roy Award in 2018. He is one of the co-authors of Consensus on Lipid Guidelines, and he had multiple national and international publications. He was also recipient of Suvarna Karnataka Rajyotsav Awardee in 2005, and he is also the secretary of Asha Diabetics Trust. So we are really privileged to have you, sir, Dr. G.B. Sattur. Now this stage is yours. We are eagerly waiting to learn from you. Over to Dr. Sattur, sir.
Yeah, Dr. Shabu, thanks a lot for your introduction. And I just go to the slides, if I can just open it. Am I audible, please?
Yeah.
Yes, sir. You are audible and your slides are visible too.
Okay, great. Thank you. Primarily, thanks, Dr. N.K. Singh, for sort of bestowing this very tough topic, which is rarely discussed on any platform. Insulin resistance from molecular mechanisms to clinical management. This one slide conveys it all. How the cells continue to say no to the normal intake of the carbohydrate. Now, the insulin resistance, by definition, is a higher concentration of insulin that is required to maintain normal glucose levels. On a cellular level, insulin resistance is defined as insufficient strength for insulin signaling from the insulin receptor, INSR, downstream to the final substrates of insulin action involved in various metabolic aspects of cellular function and crosstalk. In the absence of crosstalk, insulin wouldn't do the job because the action of insulin is beyond the glucose. It's also defined as a state of reduced responsiveness of insulin targeting tissues to the physiological levels of insulin. Now, what about the epidemiology? Premenopausal women exhibit lower incidence, although the effect diminishes severely when a woman reaches the postmenopausal age. Specifically, female sex hormones, including estradiol, protect female POMC neurons from IR by enhancing POMC neuronal excitability and coupling insulin receptors to transient receptor potential channel. Now, there are certain common sense induced modifiable factors for contribution towards insulin resistance, like diet, exercise, smoking, sleep and stress, irregular daily eating habits, where probably 60 to 70% of us who are on this meeting now do have, in view of the nature of our work, irregular eating can occur, and a poor sleep. And sleep, as we know, has gained huge importance And even in a place like Hubli, we recently inaugurated a sleep clinic in Hubli. Only one is in Bangalore. After that, we have in Hubli. So, I mean, importance of sleep in no way can be undermined. The circadian clock disruption might also be an important factor in developing an IR. I have various factors like clock gene mutation, disturbed sleep cycle, shift work, which is because they work through the night. They can't expect to have 7 hours sleep through the day. And jet lag. Some younger generation, jet lag is replaced by discotheques, which normally close by 2 a.m. or 3 a.m. The contribution of metabolic mediators, adipokines dysregulation, and the IR. Adipokines, they're like adiponectin, leptin, resistin. In addition to cytokine, chemokines are also there, like TNF alpha, interleukin 6, interleukin 1 beta, and monocyte chemoattractant protein 1. Dysregulation of these adipokines is implicated in the onset of obesity, IR, type 2 DM, cardiovascular disease, hypertension, and metabolic syndrome. It's important to realize adiponectin is the most abundant protein secreted by adipose tissue and exhibits potent anti-inflammatory properties. Now, what about stress? Is there any role of stress with insulin resistance? Yes. If we just go on to the left side, let's take an example, a beta cell function. Stress effects on insulin sensitivity, adverse influence on islet cell function by overactivation of immune responses, inflammatory cytokines, or apoptotic processes. Like that, even lipid metabolism, immune system activity, ANS, RAS activity, and certain other endocrine issues. All in all, stress does worsen insulin resistance. What about some other factors that have an impairment of insulin action, like lipotoxicity, increased adiposity, especially the Indian visceral adiposity, enhanced inflammatory signaling, part of the visceral obesity more than a generalized obesity. That's the reason why we have the vascular problems 1 decade earlier, and it is multi-vessel rather than a single vessel in most of the people when it comes to coronary artery disease. Endoplasmic reticulum stress, then mitochondrial dysfunction, increased free fatty acids. This slide can be quickly summed up. On one side, you have obesity, dealing with the adipocyte hypertrophy, which is one of the hallmarks of obesity. And then you have from inflammation on the right with hepatic steatosis. Now, all in all, a decreased adiponectin, increased resistin, increased IL-6, TNF alpha, and IL-1 beta, and increased PI1 and RBP4. The reaction on artery leads to atherosclerosis, and on the muscle and the liver, insulin resistance. Now, diabetes, by 2045, we are probably told some figure, and that figure is likely to keep on changing. Suffice to say that at least there is around 15% of diabetics and could be equal number of pre-diabetics. There are certain drugs that can worsen insulin resistance, like rifampicin, and some of the drugs, antipsychotic drugs, and steroids. We use steroids extensively, so it doesn't just upset the blood glucose level, but it could also be an underlying IR. Certain acquired influences are inactivity. I keep on writing in CME India quite a few times as comment. 32% of the Indians do not exercise. That is probably an under figure. And I put it to around 50%. Overeating, aging, medication, and elevated free fatty acids. Gut microbes, do they have any role? Yes. Those living in the gut are key distributors to host metabolism and immune function through mediating the interaction between host, environment, or releasing metabolites and cytokines. Although the composition of human gut microbiota remains relatively stable from around age 3. I was not aware of this, that you already start forming a good mycobacterial flora in the intestine by the age 3. And gut microbiota undergoes an increase in diversity. And of course, the composition keeps on changing. Now, the circadian rhythm, insufficient sleep, less than 7 hours, and circadian misalignment may lead to modifications in gut microbial structure and function. Social jet lag, I have written, apart from the normal jet lag, because going on to discotheques, as I said, which closes by 2 a.m., 3 a.m., is not uncommon for many young individuals in our country. Antibiotics, quite some clever physicians invariably write probiotics with antibiotics. I think we have some ground there. Short-term antibiotic exposure can directly perturb gut microbiota, reducing bacterial diversity, metabolic activity, disrupts intestinal integrity, which is a major cause of concern. Gut microbiome dysbiosis. Growing evidence in the last 2 decades suggests that the gut microbial dysbiosis contributes to increased risk of metabolic defects like obesity, IR, and type 2 diabetes. Several studies show that obese adults harbor reduced gut microbial diversity and altered microbiota composition compared with adults exhibiting normal weight. So I think there is a rationale to put these supplementing drugs that are definitely available in the market to enhance the gut action. What about the remedy for the gut microbiota? Some strategies have been developed, like fecal microbiota transplants, probiotics, supplements we invariably give, in combination with medications, and of course, the healthy lifestyle. Now, IR can be linked to a cluster of abnormalities, like in the heart, you have cardiomyopathy. In the CNS, you have impaired energy homeostasis. And there is also increased risk of having a malignancy, breast, uterus, cervix, colon, esophagus, pancreas, kidney, and prostate. Looking at this, it looks like the female malignancy is a bit higher. And I have not got any literature on that, but somebody else who knows can discuss it further. Then, of course, you have lipotoxicity, then CKD in some people, MEFLD is quite well known, and PCOD is quite well known. That is the reason why, because of such a huge impact, insulin resistance has been termed Medusa of the 21st century. What about the cardiovascular disease now? Mechanisms of IR that contribute to cardiovascular disease, chronic hyperglycemia, not being able to maintain their A1C, dyslipidemia. Even if you start them on statins, good number of patients stop in between somewhere. Endothelial dysfunction, and of course, inflammation. IR contributes to endothelial dysfunction by decreasing nitric oxide production via P13K and AKT pathways. We know that in insulin metabolism intracellularly, P13K, AKT pathways are extremely important. Anything that disrupts is really going to cause the problems. And ROS production is increased, prothrombotic factors, inflammatory markers mediated by the MAPK and the ERK activity, which if you go through one of those insulin signaling cartoons or a chart, one would be able to know it better. Polycystic ovary syndrome and IR. These women show higher increased comorbidity with obesity, dyslipidemia, hypertension, and diabetes than healthy women. It leads to compensatory hyperinsulinemia, which stimulates gonadotropin releasing hormone gene transcription through MAPK pathway, increases LH pulse secretion, thereby significantly increasing ovarian androgen synthesis. Androgens also trigger lipolysis, increase circulating FFA, and lead to IR. Androgens decrease, this is an important point. Androgens decrease the type 1 muscle fiber with highly oxidative and insulin sensitive properties, while increased type 2 muscle fibers that are glycolytic and less insulin sensitive. IR and hyperandrogenemia continuously stimulate each other in a vicious cycle under the condition of PCOS. I think until we realize the last sentence, where we not just you put the patient on metformin and back them off and probably come back. We know that now many young girls are exposed to media, and I see many of them premarital counseling for their possibility of getting pregnant. So I think we really need to be proactive when it comes to PCOD. Alzheimer's disease, we thought it was disease of the West, but I'm sure all on the evening here in the meeting, many see at least 2 to 3 patients per week. It increases the risk of AD and related dementias, which could be ischemic dementia. And later on, it becomes a bit difficult to distinguish AD from the ischemic dementia because the MRI reports go on saying some cerebral atrophy, few scattered infarcts. But AD is actually a brain specific form of diabetes that exhibit increased amyloid beta plaques and impaired glucose transportation, energy metabolism in hippocampus, and inflammatory pathways. Pioglitazone, rosiglitazone, by reducing the tau and the ABA deposits in the hippocampus and improving the neuronal plasticity and learning, meaning the glitazones are one of the excellent drugs to reduce the insulin resistance. What about chronic kidney disease and IR? Reduced renal excretion leads to abnormal plasma adipokine levels, including leptin and adiponectin in CKD patients. Leptin may also be considered as a uremia toxin through pro-inflammatory effects, while adiponectin mediates insulin sensitizing and anti-inflammatory process. What about malignancy and IR? IR increases the risk for different cancers, including colon, liver, pancreas, breast, endometrium, thyroid, and gastric cancer. Diverse cellular and molecular mechanisms are involved in IR relating to cancer. Increased insulin, in addition to IGF-1 and 2 levels, critically influence tumor initiation and progression in IR patients that have some genetic screening and quite a few methods that the oncologists today literally give a tailor-made rather than an en bloc chemotherapy for malignancy. The diagnosis and therapeutic strategy. Yes, I mean, there is frequent urination, excessive thirst, the classical book description, where we see probably around 30-40% of patients with DM and IR. But at the same time, craving for sweets and safety foods. And many articles, one article also was there in CME India posting, where craving the Western obesity in teenagers and early menarche in girls and in boys having the secondary sexual characters by the age of around 10, which used to be around 13, 14 some time ago. And of course, measurement methods of insulin resistance, we all know GTT or insulin tolerance test, hyperinsulinemic, euglycemic camp, coma, etc. I think those who are interested in research will probably go into this. What about the therapeutic strategy of IR? No medications exist currently that are specifically approved to treat IR. One has to target both inflammatory pathways and metabolic dysfunction for the effective therapy of inflammation-induced insulin resistance. That's how, in recent times, coronary artery disease has been cardiologists have been impressing that it's basically an inflammatory disease, and so are many ischemic episodes in other organs. In lifestyle, diet, we just talk of diet. This also comment was also made by me on CME India that a busy physician or a busy endocrinologist could have a nurse who could explain, or the doctor himself can take more time and work diet. Why diet am I stressing as much as exercise? While I love exercises and speak a lot on the lifestyle, diet is important because in India, every 50 kilometers, the diet changes. I'm from North Karnataka. We eat more of jawar roti and go up south north here, Karwar, Sirsi, the sea belt. They eat fish and rice for breakfast, fish and rice for lunch. No marks for guessing that it is fish and rice for the dinner. And large amount of carbohydrates are important. Diet advice is important. One example of my patient I quote in on every stage is I had one Brahmin patient who used to come to me for about 10 years, and HbA1c always hovered around 6.5 to 7.5. And someday he asked me, "Sir, can I eat some Satyanarayana Prasada?" I said, "No problem, you can eat some sweet." 2 months later, he comes with a 350 milligram random sugar. Then I said, "Prasad, what happened? You had an excellent control. Why this 350?" He said, "Yeah, the blame was on me. You only said I can eat sweets once in a way. But I am a pujari in a temple, and we have 8 to 10 Satnarayana puja every day." So his sugar was 360. So one has to be extremely cautious in advising the diet. Look at the low glycemic index, and it is worthwhile going in for vegetable, fruits, whole grains, lean meats, or beans, something like an Indian modified Mediterranean diet. Then regular physical exercise, 30 to 45 minutes is what Western books say. But I think we need 60 minutes because of increased insulin resistance and physical inactivity. Activation of muscle cells that increase AMPK activity, thereby inactivating TCB1D1 and promoting GLUT4 translocation to cellular membrane, which I think is extremely important, the last part of this sentence. And what is more important in real world, by losing just 5 to 7% of body weight, you can prevent or delay 60% of diabetes and ameliorate insulin sensitivity in the obese. I think this point probably should be stressed to each patient. Yeah, this is the other advantages you are going to have by just losing. And many dietitians advise keep your aim at half a kilogram loss per week. So it comes to around 2 kilos. But even that is difficult, we all have seen in our practice. The therapeutic strategy of IR starts with the physical exercise and lifestyle modification, as I said, and to have a healthy dietary pattern. Drugs like metformin reduce glucose absorption, and we have insulin injections there, glitazones, GLP-1 receptor agonists, sulfonylureas. Bromocriptine was introduced with a great hype. I don't know if it is still available. I never used it because I thought it was a very poor controller of the blood glucose. Metformin, DPP4 inhibitors, alpha glucosidase inhibitors, they slow carbohydrate digestion, and cholesterol is also available in India. I don't know right now, reduces glucagon secretion. Just look at metformin. It's a first-line medication, most widely prescribed insulin sensitizing agent, and it is very friendly, mixes with a large number of classes of anti-diabetic drugs. And we also know that metformin is the first combination to go with any of the other drugs, and increases the insulin receptor tyrosine kinase activity, enhances glycogen synthesis, increases the recruitment and activity of the glucose transporter GLUT4, In 2022, a good study was done. I forget the name of the author, where the metformin action compared to all other things, this increasing the recruitment and activity of the glucose transporter GLUT4, which is normally idle, promotes re-esterification of free fatty acids, inhibits lipolysis, which may then indirectly increase insulin sensitivity by reducing lipotoxicity. Sodium glucose co-transporters, that is SGLT2 inhibitors, they exhibit beneficial effects for reducing IR and protecting pancreatic beta cell function. What about glitazones? PPAR gamma agonists. They are used for diabetes. Adipocyte lipid storage is enhanced. Decrease ectopic lipid accumulation is an important point. Improves insulin sensitivity. I think metformin and glitazones are the most powerful insulin sensitizers. Unfortunately, these agents have produced limited success due to reduced efficacy, low tolerability, and significant side effects like hypoglycemia, weight gain, bone fractures, and vomiting. So it is urgent to find out some new drug. This was in 2003. But I think one need not really be too much worried because glitazones are easily affordable. And I haven't seen any malignancy of the bladder related to this drug so far. Or maybe the patients may not have come back to me because they may have hematuria, things like that, and end up with the urologist. But nevertheless, I think there need not be fear of either a bone fracture or a CA bladder. The pharmacological interventions, anti-inflammatory agents like aspirin, ibuprofen, as well as selective inhibitors of inflammatory pathways like TNF alpha antagonists and IL-1 beta blockers to reduce systemic inflammation and improve insulin sensitivity. Several other clinical medications, including anti-adrenergics such as salbutamol, salmeterol, and, and formoterol, HIV protease inhibitors, atypical antipsychotics, and some exogenous insulin that may improve IR because of the disordered insulin signaling. I think it's worthwhile looking at our patients of bronchial asthma who get not just one who is in remission, a bronchial asthma or a COPD patient who gets repeated exacerbations requiring steroids and frequent hospital admissions could probably a guy that we test for insulin resistance. Now, to reduce insulin resistance, some in pipeline, such as some drugs named BFK B8488A, the anti-FGFR1 by KLB agonist antibody mimics the effect of FGF21 and causes short-term weight loss and increases insulin sensitivity. Chromium picolinate administration lowers blood glucose and insulin levels in patients with type 2 diabetes. So there are certain things coming up. Now, what about the inflammatory markers in IR? High sensitivity C-reactive protein is commonly used biomarker for cardiovascular risk and systemic inflammation, insulin resistance, metabolic syndrome, and an increased risk of cardiovascular events are all linked to elevated HSCRP and interleukins. The pro-inflammatory cytokines like IL-6, IL-1 beta, and interleukin 18 are linked to the etiology of metabolic diseases and insulin resistance. TNF alpha is an important modulator of insulin resistance, causing IRS signaling, obesity, type 2 diabetes, and other metabolic diseases associated with elevated levels of TNF alpha. When all this background information, what worsens IR, what improves IR, is so important in day-to-day practice that we use the drugs that could sort of break this cycle. Now, just a bit on adipokines. Adiponectin is a hormone produced from adipocytes, has anti-inflammatory, insulin sensitizing characteristics. Obesity, IR, CV risk are linked to decreased adiponectin levels. Leptin, adipocytes secrete leptin, which controls hunger and energy balance. Obesity and insulin resistance are associated with elevated leptin levels, which are indicative of leptin resistance and dysfunctional adipose tissue. Lipid biomarkers like FFA, by increasing fat accumulation in non-adipose tissues and disrupting insulin signaling, elevated circulating FFAs contribute to insulin resistance. What about the imaging techniques to diagnose IR? MRI and the PET scan, dual energy X-ray absorptiometry, and computed tomography. DEXA and CT can probably be called gold standard in imaging for IR. Now, the molecular and genetic biomarkers, single nucleotide polymorphism, SNPs, genetic variants linked to gene related to inflammation, such as TNF alpha and interleukin 6. Gene expression profiling. This techniques enables a thorough examination of the gene expression patterns linked to insulin resistance and inflammation, which means the development of tailored therapeutics may be aided by molecular profiling approach. Like now, this has begun in a high-end center, centers for oncologists. They literally sort of tailor make the chemotherapy. So that is probably going to come treatment for IR also. Artificial intelligence and machine learning, identification of predictive biomarkers, disease subtypes, therapeutic response profiles can all be announced by the AI. Machine learning algorithms to large-scale omics data sets, the development of innovative therapeutic approaches and individualized treatment plans for inflammation-induced insulin resistance. I think this individualizing the treatment probably takes precedence over the next 1 to 2 decades in IR. So thank you for your attention. After 2 weeks of dieting, Larry's fat cells decided to go out for a pizza, meaning the lifestyle that you'd like to impress upon is not really easy for patients to follow. So just something about preventing type 2 diabetes. One could see here the adipose tissue on one side, liver and muscle on the other side, robust beta cells, hyperinsulinemia, weak beta cells, hypoglycemia, fat accumulation, insulin resistance, weak beta cells. Try to attack any one of them. One could probably be able to prevent type 2 diabetes, if not prevent, postpone type 2 diabetes, at least in those individuals who have a very strong family history. So all in all, insulin resistance is something that is undoubtedly seen in Indians because we have earlier coronary artery disease, more than one vessel is common, mortality, morbidity is pretty common, especially in diabetics who may have autonomic neuropathy. I think it's very important that insulin resistance be managed at the diet level and the exercise. As we already said, 30 minutes of Western, 150 minutes per week doesn't hold good for Indians. I think we should insist. If we insist on 1 hour, they do 30 minutes. If we insist on 30 minutes, they do 15 minutes. And make certain most Indians don't wear the shoes. Make certain, tell your patients, you get the walking shoes, running shoes worth 2,000 in Bata to 2 lakhs on Amazon. Whatever his or her purse allows, they should buy. These sort of real world issues are extremely important because most of the patients, I'm in two-tier town. So it's not uncommon for many patients to just come on slippers, move around on slippers, go on the hot stones to many temples. I don't know if I told this audience, there was one IS officer who was next to the PMOs, very helpful to PMO, not during this regime, previous, 20 years ago. And he went around Tirupati Balaji temple around 2 times on barefoot, came back with huge blebs on both of his feet. He was admitted for about 2 weeks. So I think these real world issues are very important. So thank you very much for this opportunity of discussing insulin resistance, the molecular mechanisms, the clinical outcome. So what about those who say that they don't have time for the exercise? They could be weekend warriors. Weekend warriors, although not as good benefits as the regular exercisers, nevertheless, any walking, any amount of physical activity is better than no activity. It's very important to sort of encourage physical activity. So, physical activity and the diet are the two main things now. For those who do not want to exercise, they can be closely told in the ears. The only alternative to exercise is to get admitted to the hospital with non-communicable disease like diabetes, malignancy, and cardiovascular disease. Thank you very much. Good listener.
Thank you, sir. Thank you so much. Nice presentations, leadership presentations. So, other panelists, any comment?
I think, sir, thank you very much for this beautiful presentation. And sir, as you had rightly emphasized the role of lifestyle modification, very recently, we had given one small acronym to fight against this metabolic syndrome or insulin resistance Ravana, that is the Rama mantra. Very recently, we had published in CME India, so that Rama acronym, what we had discussed, I just want to focus that Rama means R for right eating at the right time, A for activity, as you had mentioned, then M for mindfulness and mental well-being to reduce anxiety, stress, and finally the A, that also important, the adequate sleep. So good quality and quantity of sleep and following the chrono physiology, that is also very important. So once again, thank you, sir, for this beautiful presentation. I think other panelists also can give their opinion.
Dr. Sathur, sir.
Yeah, so okay, Dr. Vishwaya.
Yeah, just one, sir. On the anti-inflammatory drugs, there's one study is going on using the colchicine in the group of IR patients without diabetes. Sir, any comment on this, sir?
Not really, because I haven't come across any literature on that. So I'm unaware of the role of colchicine in this.
I think our Dr. Balasubramanian sir, can you have some comment on this talk and then any question?
Am I audible, sir?
Yeah,
Yes,
fine.
sir. You are.
It's an excellent, actually, coverage by Dr. Sathur. Thank you very much, sir. It's overall, actually, very good presentation. As a cell biologist, I've been a lot of interest in insulin resistance and molecular mechanisms, and I have done a lot of work, actually. It looks like that, actually, lipid is actually a big culprit. And I used to tell that, actually, diabetes is actually, the problem is right fat in wrong places. That is called, ectopic fat kind of thing. And the myocellular lipid content is playing an important role in insulin resistance. And still, actually, as Sar told, actually, the gold standard hyperglycemic is, the clamp studies are very difficult, and people are actually using HOMA-IR. Even HOMA-IR has to be actually studied in, for cutoffs and reference values. Recently, ICMR has actually introduced actually a task force for reference values for clinical laboratory. So we definitely need actually, the HOMA-IR cutoffs in, healthy individuals, the 90% percentile, and then actually, other, the syndromes kind of thing. And I saw actually some of the papers very recently, the simple triglyceride glucose index has been used as a insulin
Absolutely.
surrogate
Yeah.
marker.
Absolutely.
And again, ethnic specificity as a reference values and ROCs has to be standardized thing. As per Dr. Mohan, actually, diabetes, and I've been working for long, for the last 25 years. Very quickly, both the Caucasian population and also our own Indian Dr. Mohan study, they come up with a subcluster of diabetes type 2, which is called the SIRD, severe insulin resistant diabetes. I was wondering actually, they may not be actually the algorithm treatment, they may not actually, respond well. We need actually, the specialized drugs and some of the pipeline drugs you have been mentioning. And definitely, my own studies actually, connecting inflammation and senescence. So probably several organs, including, skeletal muscle, beta cell, liver, some organ senescence, probably there may be adjuvant anti-senescence or senolytic drugs may be possible in the future, and future studies should actually establish this.
I think very nice input. So, is there any question in the chat box, Dr. Osili? Can you see?
Any comments by Dr. Akash, sir?
Sir, he will give his comments.
Okay, in the okay.
Yeah, so
I'm just
but,
checking the
yeah, you please check.
details
So, sir,
from the links.
yeah,
Yes,
Dr.
I'm doing that.
Satur,
I'm
sir,
Not yet.
I had one small question, Satur sir.
Yes, sir.
You had mentioned about different clinical and biochemical parameters. So how, as a metabolic physician, we should give emphasis on routine check of abdominal circumference of all of our patients, and how it should come, just like a stethoscope. I think the tape, measuring tape, has an immense role in the metabolic physician's chamber. And at least I think this is a time when we all physicians should have that, and to screen, because this is a very simple test without any cost, and that can tell us a lot of news. So what is your take on that, sir?
Absolutely. Right from the time I returned from UK in the early 90s, the tape has been with me in the clinic. And just as a souvenir, I kept the first torn out tape. So I think you are very right. Every physician, every general practitioner at least, must have a tape and measure the waist. It's very important. And that's how the, instead of BMI, the roundness score came, where you say tape is enough, both for height and the waist circumference.
Thank you,
One
sir.
point, sir. So far, we were discussing about the treatment part, basically, that type 2 diabetes and all obesity. But the point is that we are regularly getting young persons, the rather teens, with increasing diabetes, type 2 diabetes, young persons. So how should we start the any policy changes or something to how to assess so that we can patient don't turn out to be diabetes and then come to physicians? From the school level point of view, the regular checkup should be done. Who are more prone to have a higher, even higher?
Yeah, I think that's a very good, point from the real world point of view. And this is again, I keep on writing in CME India platform that India has 63% young adults and 32% do not exercise in any form. So there are people who use the lift to go to the gym also, which is on the first floor. So, I mean, this is the style we have in India. I put that slide somewhere. So the point you're making is very right. This must be instilled right into the adolescence, and they must start doing in the school itself.
Yes.
But you know that how schools and unfortunately have grown like mushrooms all over, and no playground is being specified by the government, unfortunately. But still, I think probably there is definitely a scope for adolescents to start with, because as we know, process of atherosclerosis starts towards the end of first decade, somewhere around 8 or 9 years of age, to start building plaques.
Thank you.
One more point I want to emphasize, insulin resistant and insulin secretion has to be well studied in youth type 2 diabetes. If you look at, such study and RISE studies, see the regular pharmacological treatment, these youth diabetes are not actually responding well. So probably the pathogenesis of insulin resistance pattern may not be actually a difficult or different in these people. We need actually longitudinal studies on this.
Yes, that's true.
I think one point, take-home point from this excellent meeting on IR would be, like Dr. Shambhu was telling, every physician should have a measuring tape in his clinic. In fact, 3 months ago, from our Asha Diabetic Trust, we distributed to 104 physicians in our area. Many had one, but we thought, let us, remind them to use it regularly.
That's true, sir. I think there is no questions in the chat box, but I think Dr. Balasubramanian sir was telling about how to diagnose the insulin resistance. That is very, very important. So we don't, we're going for every case, even for this TG index and this HOMA IR. So what are the clinical pointers? Can you just tell what are the clinical pointers which can tell without also in type 2 diabetes, only the resistance portion is not working. There is secretory defect, definitely there is some subsets of patients. So how to differentiate clinically, sir?
Yeah, one, although the classical type 2 DM symptomatology, like polyphagia, polydipsia, we rarely see it in most of the patients. Acanthosis nigricans, either on the back of the neck or in the axilla. And some people have in both the regions. And what is interesting, even in the darkest skin, you will be able to make out the acanthosis nigricans very easily. So I think that's really a good physical point. And some people may have sort of xanthal asthma and lipid abnormality that might come out in such people.
Sir, in your risk factor slide, you showed many things like the risk factors causing impairment of insulin action. Lipotoxicity is okay. In case adiposity, you told this is also good. Enhanced inflammatory signaling. So how to know about that in clinically? You also told about the mitochondrial dysfunction. So is there any test to know that, or dysfunctional insulin signaling? How to know this in our clinical?
Very good question. These all signalings are basically the talk between the different processes going on inside the cell called crosstalk. And unless there is crosstalk, the entering, insulin being there to act, and the glucose entering the cell, the glut for activity, all these are interdependent on the crosstalk. So these days that word is frequently used. Crosstalk simply means coordination of different pathways, both extracellular and predominantly intracellular.
Okay, sir.
And
So
there
I
are no,
think, sir,
and as I
regarding,
said, sir,
sir, so there, suppose sir, there is a patient is in the pre-diabetic state and there is insulin resistance, and we want that it should not develop to diabetes state at all. So, well, lifestyle modifications you told, but what about the SGLT2 inhibitors? Do they help also in this scenario? Metformin you are knowing, pioglitazone quite good, but the new drug, this SGLT2 inhibitors, can we use to treat also this insulin
in
resistance?
fact, recently one of the articles said that in type 1 diabetics, in some of the people, SGLT2 inhibitors were sort of on an experimental basis. So it definitely has a wider scope. But is it as effective as metformin? I'm not really certain because I haven't got comparative study of SGLT2 or DPP4 inhibitors with metformin in IR scenario.
Dr. Akash, I think we are end of the seminar. So, can you just request all our panelists to give the take-home message, and then you should conclude and give the vote of thanks. First, you just request for the take-home messages from each of the panelists.
So, first of all, I will have my comments on this topic. So,
Yeah.
basically, this was a very, very relevant talk by Dr. Satur. And if you see all the authors who talk about metabolic health, who talk about longevity of life, they all talk about decreasing insulin resistance. It may be Dr. Jason Fung, it may be Dr. Peter Attia, all the famous authors of books to prolong the longevity. All of them basically talk about decreasing insulin resistance and all the strategies which are there to increase insulin resistance. The major strategy is lifestyle modification. For that, you have a lot of things like intermittent fasting, like fasting, traditional fasting, exercise, diet restriction, restricting simple carbs, and going more towards the protein, fat content. So all of these, basically, everything is tailored to decrease the stimulation of insulin secretion and to decrease the levels of insulin in the body. If you can decrease the levels of insulin in the body, the insulin resistance also gradually decreases and you have better improvement in the atherosclerosis. The subendocardial dysfunction also is also ameliorated. You have better lipid management, better carb management. So the energy metabolism of the body also is better basically. You have weight loss also. So everything is tailored around decreasing insulin resistance and decreasing the levels of insulin. And for that matter, all the strategies are there. And as Dr. Satur has said, the major strategy is and will remain to be lifestyle modification in the form of diet, exercise, proper sleep, meditation, and all the things which are tailored, basically weight loss to tailored to decrease the levels of insulin in the body. The inflammatory markers that we also should look into are HSCRP, which is also one of the markers. We should also look at the fasting insulin levels. Anything beyond 6, basically, we should be counseling the lifestyle modification to the patients. These are apart from what we discussed. We also should have a very keen look at the lipids, basically, because the HDL and triglyceride ratio basically is very, very important, basically, because if you have less triglycerides and more HDL, that suggests that the metabolic health is very good. So basically, this is the most pertinent talk of the century. Everything is focused to decreasing the insulin resistance, and that should be imbibed with all the physicians treating the patients. I, at this juncture, would like to invite Dr. Shambhu Samita to give his take-home message for this talk, important talk.
Thank you, sir. Thank you. So, 1923 is a very special year for insulin because those who had discovered insulin, they won the Nobel Prize in that year. But at the same time, 1923, when there was a very famous scientist called Kailin, he had for the first time had proposed that metabolic syndrome or insulin resistance, which could be associated with 3 things, that is hypertension, hyperglycemia, and hyperuricemia. That paper was being published. So now it is not only about insulin deficiency we need to give emphasis. We now need to talk more about insulin resistance. And I think one of the very important message from Satur sir's lecture that we should carry a measuring tape, and at least we should measure the abdominal circumference of all our patients. And that is very important. And mass screening is also important to adopt a preventive policy that is very much required. And one letter to editor we had published in Mohan sir's journal last year last year 2023, influenced by our Prime Minister's project that is Swachh Bharat Mission. We wrote that letter to editor like sweeping toward a healthier India, a proposal to address both communicable and non-communicable disease through physical activity. So I request you all to go through that, because I think we need to promote our physical activity. That is what Satur sir has mentioned. Only 50% of our young generation, they are complying with physical activity guidelines. So that is most unfortunate. So once again, thank you, Dr. N.K. Singh sir. Thank you, Akash Singh sir, for giving me this opportunity to hear from this beautiful lecture and learn a lot of important issue from Professor Guru Raj Sattur sir. So thank you very much.
Thank you very much. I will now request Dr. Amitabh Vishwas to give his take-home message.
Thank you. Thank you, Sir Ashwin, sir. Thank you, Guru Raj. Thank you, Dr. Singh. Really, I learned a lot about IRs, but think after the discussions, I personally find that it should be approached much early. Even now, to think of how we can prevent insulin resistance from the adolescent groups, because regularly we are getting the obese adolescents with diabetes, with hypothyroid, even with hypertension. So we have to find out some policies or somewhere when to start screening, and for that probably we have to aware the common mass, the common people. Like we are doing awareness programs about diabetes and all. We should also plan some awareness program towards insulin resistance for the common people in our society. Thank you very much, sir. Thank you, Dr. Singh, again for giving me the opportunity to be a part of CME India. Thank you very much. God bless.
Thank you, Dr. Vishwas. I will now request Dr. Balasubramanian to give his take-home message. Dr. Balasubramanian.
Yeah. It looks like that actually, insulin resistance is important. Sometime back, actually, the New England Journal editorial, what prevents you to prevent diabetes? So prevention of diabetes is possible, prevention of insulin resistance is possible. So we have to adopt to actually, lifestyle modification. It's very, very important. So prevention is always better than cure. Secondly, I think actually, definitely we need actually better insulin resistant assessments at the clinical level, maybe a point of care device or something like that, so that we can easily assess actually insulin resistance as a surrogate marker. That is very, very important. And there might be actually, different forms and patterns of insulin resistance. It needs to be studied both at the adipose, liver, and peripheral tissue level. And brain is also very important. Both the astrocytes and neuronal insulin resistance, very, very important. I used to give talks on brain connection to diabetes kind of thing. So all these things has to be taken care. I learned a lot. Thank you, sir, Dr. Satur, sir. Thank you, everyone.
Thank you very much. I think we are at the end of the session. I will thank Dr. J.B. Satur for giving such an excellent talk. I also thank Dr. Amitabh Vishwas, Dr. Shambhu Samijdar, and Dr. Balasubramanian for excellent moderation of the session. I am very grateful to Dr. N.K. Singh for continuing with this CME activity, which is beneficial to a host of doctors across India. I thank all the doctors who have joined in this important session because their joining also makes us enthusiastic to carry on such activities. I thank Dr. Ayushi from USV for being there, coordinating the session, and managing the entire meeting of CME India. I thank USC for providing the platform for this important CME session. Thank you very much. I hand over the mic to Dr. Ayushi to formally close the session.
Yeah, thank you so much, Dr. Akash Singh sir, and thank you so much, Dr. Sattu sir, and all the expert panelists for you sharing your knowledge, time, and wisdom with us. It was a pleasure connecting with all of you. Tech team, we can